Asmita, are we good to go? Good evening, everyone, and very warm welcome to the another episode of the Indian Thyroid Society Thyroid Clinics, that is the Wednesday Special Thyroid Clinics. I, Dr. Ganavi, take the pleasure in welcoming all of you to another enthralling session.
Yeah. Asmita, are we go?
Asmita?
So opening. I, Dr. Gandhi, the session. Asmita?
Is there something? There's no problem with the network, no?
Asmita?
What is the problem with the computer? It's very slow.
Hello.
Ha, Asmita.
Hello.
Yes, ma'am. Hello.
Hello.
When I'm ready.
Audible.
No. Hello. Hello. Hello, am I audible?
Yeah. Good evening, everyone. Am I audible?
Yes, sir.
Yeah. Should I try run my sharing the screen?
So, Asmita, should we start?
Yes, ma'am. Yes, ma'am.
Should we
Good
start?
evening, everyone. What is
Yes,
the
sir.
problem?
Yes, sir. Yes, ma'am.
Okay. Good evening and a very warm welcome to everyone. I, Dr. Ganvi, take the pleasure in welcoming all of you to another enthralling session of the Wednesday Special Thyroid Clinics organized by the Indian Thyroid Society. So now let us go briefly through the origin, the achievements, and the publications of Indian Thyroid Society. So Indian Thyroid Society was established and registered in 2003. It is a national body of healthcare professionals with special interest in thyroid disorders. It comprises of endocrinologists, endocrine surgeons, nuclear medicine physicians, general surgeons, and ENT surgeons. ITS is a member of the Asia-Oceania Thyroid Association, that is the IOTA. It has currently nearly 2,000 members. So in the executive committee, we have the founder president, Professor R.V. Jaikumar sir, and current president, Professor Sarita Bajaj madam. Also in the executive committee, we have past president, Professor Rajesh Ratput sir, secretary, Dr. Arun Menon sir, treasurer, Dr. Mini ma'am. Also, Dr. Himagirish K. Rao sir, who is the vice president, and Dr. Pramila Kalra ma'am, who is the scientific committee coordinator, and Dr. Sujay Ghosh sir, who is the joint secretary, are members of the executive committee. So Dr. Shashank Joshi sir, Dr. P.K. Jabbar sir, Dr. Krishna Sheshadri sir are all members of the executive committee. Dr. Muhammad Riyaz sir, Dr. Sushil Gupta, and Dr. Ashraf Jani sir are also members of the executive committee. So the aims of the ITS is to organize academic activities for healthcare professionals, to promote public education and awareness about thyroid disorders, to encourage research in thyroidology, and to encourage publication in our flagship journal, that is the Thyroid Research and Practice. And also the other aim is to have the state-of-the-art publications and to award fellowship of the society and to encourage membership of the society. So the ongoing academic activities include the CMEs, the updates, the symposia, and the conferences. Also the thyroid clinics, which were initially held weekly and fortnightly, are now being held monthly. So they include journal club, case conversations, monologue, dialogue, panel discussion, meet the professor session, quiz, workshop, and CPCs. So Indian Thyroid Society celebrates Thyroid Awareness Week between May 22nd to May 28th. Also, World Thyroid Day is celebrated on May 25th. And the Thyroid Awareness Month is celebrated annually in January. So the research activities undertaken by ITS include provision of annual grants for original research studies focused on thyroid and related disorders, preferably in the Indian context. Also, the research grants are available and the details can be accessed through the website www.indianthyroidsociety.in. So regarding the flagship journal, that is the Thyroid Research and Practice, it is published twice a year in print and online. It has a quick turnaround time with electronic copies available ahead of print. So the fellowship is to be awarded to the ITS members with expertise and experience in the field of thyroidology. It will be selected by an expert panel, and the eligible members will be conferred the Fellow of Indian Thyroid Society. So the numerous publications by the Indian Thyroid Society include the ITS Clinical Manual of Thyroid Disorders, edited by R.B. Jaikumar sir. Other guidelines published by ITS are thyroid dysfunction in pregnancy, management of thyroid dysfunction during pregnancy, hypothyroidism and diabetes, management of subclinical hypothyroidism, management of dyslipidemia and thyroid dysfunction, management of depression and thyroid dysfunction. So ITS Clinical Textbook of Thyroid Disorders is the upcoming publication, the chief editors being Dr. Sarita Bajaj Madam and Dr. Rajesh Ratput sir. Also, numerous guidelines are also going to be published in 2022 and 2023, which include management of subclinical hypothyroidism, management of thyroid disorders in pregnancy, and management of thyroid carcinoma. So the website of Indian Thyroid Society is can be accessed through the link, that is indianthyroidsociety.in, which has numerous contents like link to guidelines, access to ITS journal, records of all the academic events, including online membership portal. So the membership is to be awarded to all the MCI registered modern medical practitioners in India. There are two types of life memberships which are available, which include full-time life membership and associate life membership. Full-time life membership is basically awarded to the specialists in the field of endocrinology, endocrine surgery, and nuclear medicine, and associate life membership to all the other registered medical practitioners. So the applications are invited online on the ITS website, and the details can be accessed on the following link, that is the indianthyroidsociety.in. So with that, we will be starting the today's session. Thyroid clinics is now being conducted under the monthly, probably every second or third Wednesday. It is being conducted under the leadership of our distinguished conveners, Professor Sarita Bajaj Madam, who is the President of ITS, Dr. Pramila Kalra Madam, who is the Scientific Chair, Dr. Miniji Ma'am, who is the Treasurer, and Dr. Arun Menon sir, who is the Secretary of ITS. So before we start off with this session, we will just go briefly with the today's agenda. So today we have Dr. Ipshita Mishra with us, who is the chairperson, and today's session will be moderated by Dr. Patwardhan sir. And today's program, we have two case presentations. In between, we will have a quiz by Dr. Arun Kumar sir.
And then the answers to the quiz at the end.
Yes,
the quiz. Yeah.
Following that, with the answers for the quiz, and the winners will be announced. So okay. Should we have the quiz participation rules, ma'am? Shall we begin with that?
Yeah, please. One
yes.
round of that. Yeah.
Yes. Yes. So the quiz participation rules are: to participate in the quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There will be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or the description of the question by screen sharing a PowerPoint file, and the participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is lodged, and the answer for all the questions is to be submitted at the end of 10 minutes. To read the case or description, you can close the polls using the X button and again use the polls option to answer the respective question. So,
okay, we start.
Yes, we will start the session, today's session, with the introduction of our chairperson, Dr. Ipshita Mishra. So can we have Dr. Ipshita's CV slide, please? So Dr. Ipshita Mishra is presently working as Assistant Professor in the Department of Endocrinology, SCB Medical College, Cuttack. She's done her MD Pediatrics and DM Endocrinology. She has numerous professional memberships, that is the Indian Academy of Pediatrics, the ESI, the ISPE, ACE, ADA, and the Endo Society of the United States. She has many oral presentations in ESOCON 2017 and ESICON 2018, and she had secured 3rd position as well. She has numerous poster presentations as well. She has numerous publications both in national and international journals, and she's involved in public awareness programs for diabetic patients as well as conducting CMEs. Also, she's won the gold medal in MBBS, and she's also the second runner-up of the prestigious ESI TISA in 2019. So with that, over to Dr. Ipshita to say a few words and introduce our esteemed moderator for the session, Dr. Patwardhan, sir.
Thank you, Dr. Janvi. At the outset, I would like to thank Sarita Bajaj ma'am for giving me this opportunity, and definitely my professor and head, Dr. A.K. Baliarsina sir, who has been the backbone to present our department at various forums. So it's my pleasure to invite our moderator, Dr. M.H. Patwardhan sir, who has passed DM Endocrinology from PGI Chandigarh. He was the reader in the Department of Medicine at GMC Miraj. Currently, he's the president of Maharashtra Endocrine Society, and he's also the author of Madhume, which is a Marathi book which relates with various parts of diabetes. Also editor of various monthly magazines and founder of Madhume Jagruti March, which is dedicated to patient education. He has started the Endocrine and Diabetes Research Center in Miraj, Maharashtra since 1987. Welcome, sir. It's my honor to welcome you onto this. So with this, I think sir can take over the session and introduce the first speaker, and we can start on with the first case.
Thank you very much. Thank you, Dr. Sarita. Thank you, Ipshita, Dr. Ganvi. Today's session is going to be very interesting. There are two cases to be presented by our DM students. First case will be presented by Dr. Zina. This is about thyroid-associated ophthalmopathy, which was diagnosed in a patient with hypothyroidism. We often, not very commonly, but we do see such patients, and it is important to discuss these cases. And second case will be presented by Dr. Pradhan, and it is about a Graves' disease with proximal myopathy caused by autoimmune demyelinating neuropathy, you can say polyneuropathy. Now, both these students are bright. They are beginning their career, and there is a lot of scope to improve their biodata in future. So at present, I congratulate both of them for being in the department, studying very well under Dr. Ipshita. And I request the first case should be presented now.
So with due respect, I would like to just have let us small bit of correction. The first case will be presented by Dr. Swikruti, which will be the Graves presenting with proximal myopathy.
Okay, that's okay. That's fine. That's okay. Yeah, go ahead. You can start your, yeah. Yeah. Yeah, we can see you. We can see you.
Good evening, please. Member of audience.
Your voice
I'm
is
presenting this interesting.
Your voice is breaking.
Your voice is breaking.
I'm now audible now.
Yeah.
Yeah.
I'm going to present this interesting case, Graves' disease with AIP, an unusual cause of proximal myopathy in Graves' disease. This patient, a 60-year-old male from Cuttack, a known case of Graves' disease for more than 1 year, presented with the complaints of bilateral lower limb for 7 days, unable to walk without for last 5 days. The patient was apparently all right 7 days back. To start with, he developed weakness of both lower limbs in form of difficulty in getting up from squatting position, which was active in onset, gradually progressive, and to what he was unable to walk without support. This was not associated with any history of pain, loss of sensation, bladder bowel involvement, symptoms of drooping of eyelid, diplopia, dysphagia, dysphonia, or nasal regurgitation. There is no history of any aggravating factor like strenuous exercise or carbohydrate-rich food intake. No history of any recent fever, cough, diarrhea, or any recurrent similar episode in past or classic paralysis. During his course of hospitalization, he developed weakness in both upper limbs in form of difficulty in combing his hair and raising his arms above his head. Average socioeconomic status: a farmer, married, smoker for more than 10 years, stopped 1 year back, and currently he was on tap carbimazole 20 milligram twice daily after about 3 weeks prior presenting to us. The patient is a known case of Graves' disease for last 1 year and had initially visited with symptoms of palpitations, tremor, heat intolerance, increased sweating associated with swelling in front of the neck. Over the past 1 year, he is poorly compliant with history of on and off therapy, with symptoms reappearing while discontinuing therapy. There is no history of any pain, redness, or protrusion of the eye over the past 1 year, and no history of similar illness in family.
I think
Yes,
we can't hear you clearly at all.
Hello. Dr. Sukruti?
yes.
Hello, we can't hear you, ma'am. Your internet connection is too weak.
Your voice is breaking. It's cracking in between.
Ma'am, I'll switch to a better position.
I think if possible, switch off the videos. That might help.
Keep your audio and slides on.
I think we lost. She is not there in the.
She's logging through another device, sir.
So meanwhile, we can
Just
You want to practice. Anyway, we can't do that right now. Sorry. We have to continue.
We can discuss something about the case in between.
Yeah, so you're aware of that.
I remember very first case which I saw, the thyroid had presented with difficulty in swallowing, and we used to discuss as to why he's having this difficulty.
Okay,
So
she's back, so we can continue.
Okay. Sukruti, are you going to start?
Yes, sir.
Go ahead.
Yes, sir.
I think that sounds better.
This is the Ma'am, is my screen visible?
Yes, it is now.
yes, ma'am.
I'll start again.
Yeah, the voice is better now.
60-year-old male from Cuttack, a known case of Graves' disease for more than a year,
Good. Yeah, good.
presented with the chief complaints of weakness of bilateral lower limbs for 7 days and unable to walk without support for 5 days. The patient was apparently all right 7 days back. To start with, he developed weakness of both lower limbs in the form of difficulty in getting up from squatting position, which was acute in onset, gradually progressive to the point where he was unable to walk without support. This was not associated with any history of pain or loss of sensation, bladder bowel involvement, or symptoms of drooping of eyelid, diplopia, dysphagia, dysphonia, or nasal regurgitation. There is no history of any aggravating factor like strenuous exercise or carbohydrate-rich food intake. No history of any recent fever, cough, diarrhea, or recurrent similar episode in past classic paralysis. During his course of hospitalization, he developed weakness in both upper limbs in the form of difficulty in combing his hair and raising his arms above his head. He's of average socioeconomic status, a farmer, married, smoker for 10 years, stopped a year back. Currently, he's on tab carbimazole 20 milligram twice daily, which are for around 3 weeks prior to presenting to us. The patient is a known case of Graves' disease for the last 1 year and had initially presented with symptoms of palpitations, tremor, heat intolerance, increased sweating associated with the swelling in front of the neck. Over the last 1 year, he's poorly compliant with history of on and off therapy, with symptoms reappearing while discontinuing therapy. There is no history of any pain, redness, overt protrusion of eye over the past 1 year. No history of any similar illness in family members. On examination, the patient is conscious, well-oriented to time, place, and person, with a weight of 51 kgs, height 163 centimeters, with BMI of 19.1 kg per meter square, with waist circumference 76 centimeters, hip circumference 88 centimeters, with waist-hip ratio of 0.86. On head-to-toe examination, the hair appears normal with the male pattern baldness present. Pallor, icterus, cyanosis, edema, lymphadenopathy were absent. There were no overt signs of active ophthalmopathy. There was proptosis of 18 mm, bilateral eye with hurtles, and presence of grade 2 clubbing in all digits, and presence of a plaque-like lesion over the shin of tibia. These are the clinical images of the patient showing the clubbing in the digits and presence of the plaque-like lesion over the shin of tibia. His vitals revealed a pulse of 86 per minute of regular rhythm, good volume, normal in character, with all peripheral pulses well felt and no radial or brachiofemoral delay. An arterial wall just palpable. Blood pressure was 130 by 80 millimeters of mercury in both arms in supine position, with a respiratory rate 18 per minute regular abdominothoracic, and he was afebrile. On examination of the neck, on inspection, there was a swelling in the anterior aspect of neck of approximately size 9 into 6 centimeters, which was diffuse, symmetrical, without any visible nodularity, which moved on deglutition with overlying skin normal and superficial veins visible. On palpation, the swelling was confirmed to be of 9 into 6 centimeters, firm in consistency with smooth surface, non-tender with no palpable nodules, lower border delineable with no palpable thrill, and neck circumference was 37 centimeters. On auscultation, there was no bruit appreciated. On examination of the central nervous system, higher functions was conscious, oriented to time, place, and person, with examination of the cranial nerves, olfactory nerve apparently normal, optic nerve revealing a visual acuity of 6/6 in both eyes with intact color vision, with field of vision corresponding to the examiner with normal fundus. On examination of the third, fourth, sixth cranial nerves, there was no ptosis or nystagmus, and extraocular movements normal in all directions, pupil of normal size and shape, and right reflex both direct and consciential present, and all other cranial nerves were apparently normal on examination. On examination of the motor system, bulk was apparently normal with hypotonia in all 4 limbs. Power was 3/5 around the shoulder, elbow, and wrist joints, 2/5 around the hip, knee, and ankle, with absent deep tendon reflexes, and plantar was non-responsive. All primary modalities of sensation were intact with absent cerebellar signs, and skull and spine examination was normal. On examination of the musculoskeletal system, on inspection, joints appear normal with no deformities or muscle atrophy, with decreased range of movement around all large joints, and on palpation, no tenderness or palpable crepitus. On examination of the cardiovascular system, on inspection, precordium normal with no visible pulsations or engorged veins. On palpation, the apex in the left 5th intercostal space in the midclavicular line with parasternal heave of grade 2. On percussion, left 2nd intercostal space was normally resonant with the cardiac dullness starting from left 3rd intercostal space and not extending beyond the apex. On auscultation, the first heart sound was normal. The pulmonary component of second heart sound was loud with presence of a pansystolic murmur in the lower left sternal border. Examination of the respiratory system was normal with the auscultation revealing bilateral vesicular breath sounds with no adventitious sounds. Examination of the gastrointestinal system was within normal limit. Summarizing my case, a 65-year-old male, known case of Graves' disease for last 1 year with poor compliance to therapy, presented with weakness of both lower limbs, followed by both upper limb weakness, not associated with pain or loss of sensation or any bowel bladder involvement over a period of 7 days. On general examination, BMI was 19.1 kg per meter square. Patient was normotensive without resting tachycardia. There was grade 2 goiter, which was firm without any evidence of nodules. Mild inactive bilateral ophthalmopathy was present with plaque variant of dermopathy, clubbing of digits, thyroid acropathy. On CNS examination, the patient was found to have hypotonia with decreased power in all 4 limbs, absent deep tendon reflexes along with non-responsive plantar response. On sensory examination, all primary modalities of sensation were intact. Cardiovascular system examination revealed features of loud P2, pulmonary component of second heart sound, and pansystolic murmur in the left lower sternal border, with other systemic examinations within normal limit. My provisional diagnosis was Graves' disease with mild, clinically inactive bilateral ophthalmopathy with dermopathy plaque variant, acropathy with pulmonary hypertension, not in congestive cardiac failure, in sinus rhythm with acute inflammatory demyelinating polyneuropathy. The differential diagnosis for this case is thyrotoxic periodic paralysis, Basadow's paraplegia, which is thyrotoxic polyneuropathy, a rapid correction of T3, T4 excess leading to myopathy, acute exacerbation of thyrotoxic myopathy, and polymyositis. The investigations revealed electrolytes were normal with normal lipid parameters and euglycemia. The TFT was serum TSH was 0.03 MIU per ml with FT3 6.9 picogram per ml, FT4 1.8 nanogram per ml, calcium profile normal and CPK normal. ECG revealed a normal sinus rhythm. The 2D echo showed mild pH with mean pulmonary arterial pressure 36 millimeters of mercury with mild tricuspid regurgitation with dilated right atrium, right ventricle with ejection fraction of 61%. The PFT was within normal limits. This is a chest X-ray PA view, a probably overexposed film with trachea central, bony components normal, with an enlarged cardiac silhouette and a mildly dilated pulmonary trunk with the costophrenic angles clear with the increased bronchovascular markings. This is the X-ray of bilateral wrists and hands showing longitudinal fissuring in the third and fourth distal phalanges of the left hand, probably traumatic, with the presence of subperiosteal elevation, subperiosteal reaction in the radial border of the second left proximal phalanx, and ruling out other cause hypertrophic osteoarthropathy in the form of absence of any laminar subperiosteal reaction and absence of involvement of the long bones. The nerve conduction studies revealed a motor demyelinating axonal neuropathy with EMG revealing a neurogenic pattern. So a final diagnosis is Graves' disease with mild clinically inactive bilateral ophthalmopathy with plaque variant of dermopathy with acropathy with pulmonary hypertension, not in congestive cardiac failure, in sinus rhythm with acute inflammatory demyelinating polyneuropathy. So the treatment course was such that anti-thyroid drug therapy was continued. Though the duration of weakness exceeded 7 days, in view of progressive weakness, intravenous immunoglobulin therapy was planned, and following after consultation with the Department of Neurology and following IVIG therapy, there was improvement in symptoms in the form of improvement in power of the lower limbs to 3/5 and power of the upper limbs was static, and there is still progressive improvement in his motor part. So regarding the review of literature for this case, neuromuscular disorders have been described in Graves' disease previously. The incidence of AIDP in Graves' disease has been described in a few handful of case reports. Case reports of areflexic paralysis without sphincter disturbances and some occasional sensory deficit has been described in patients of Graves' disease in the late 1800s, which was first described by Charcot, and this term was given, this condition was termed as Basadow's paraplegia, an acute thyrotoxic neuropathy by Geoffroy. But recent reports on this Basadow paraplegia, they have been contradictory, with some terming it a misnomer and describing this clinical presentation to be the occurrence of an acute idiopathic polyneuritis, possibly associated with an underlying predisposition to autoimmune diseases. But other case reports, they term Basadow paraplegia to be a result of severe thyrotoxicosis with symptom improvement on treating the underlying hyperthyroidism, and improvement is not seen on giving IVIG therapy. So AIDP and Graves' disease, they have been described together, and the association is believed to be triggered by interactions between genetic and different environmental factors. With this, I conclude my presentation. Thank you.
Good presentation. We would like to open the case for discussion. Before that, I would say that many times we see muscular weaknesses and syndromes in Graves' disease. And I was just telling before Samskruti was about to present that I had seen patient coming with difficulty in deglutition and was being investigated by neurologists actually. And it turned out to be thyrotoxicosis. And in that case, I remember it was also acute onset and it recovered fully after controlling thyrotoxicosis only. Another interesting part which we documented about 30 years ago, 35 years ago with Dr. Digambar Behra is there is a respiratory paralysis, intercostal muscle paresis, you can say, where people present mainly with dyspnea on exertion, and on pulmonary function test, you find restrictive lung disease rather than obstructive. So apart from this, GBM or like syndromes are quite rare in day-to-day practice of Graves' disease. So may I make this case open for discussion and let Dr. Sarita Madam start the discussion.
Yeah, thank you. I think Swikriti, that was a very good case. You gave us some differential possibilities, right?
Yes.
Could you elaborate on each of them and tell us how common is each one of them in association with Graves? Which one is the commonest? Which one is the least common? And you've already said that there is one controversy regarding one of the differentials that you have placed, right?
Yes, ma'am.
Yeah, so the differentials that you had listed, can you just elaborate upon that?
My first differential diagnosis was thyrotoxic periodic paralysis,
Yeah.
which is commonly it is seen in Graves' disease, and up to 2 to 5% it has been reported. Differential in this case, why it is not thyrotoxic periodic paralysis, considering the age of the patient, it usually presents in a younger group, 20 to 40-year-old Asian males who have a genetic predisposition for thyrotoxic periodic paralysis. And usually there is a history of a high carbohydrate-rich food intake or strenuous exercise or a triggering factor for the weakness. And it occurs in episodes, and which can last for a few hours, 3 to 4 hours to up to 3 to 4 days. So that was my first differential diagnosis. Next, also rapid correction of thyrotoxicosis, rapid correction of the free hormones.
What about the investigation part? You just elaborated the clinical manifestation.
Electrolytes, there will be hypokalemia in TPP, and which in my case, there was electrolytes were normal. That is
we also talk of normokalemic periodic paralysis, or do we not?
Yes, ma'am. Normokalemic, it has been classically described as channelopathies, ma'am, with which is mostly autosomal dominant, and it is inherited, and familial history is present. Whereas in TPP, there is no family history; it is sporadic, and potassium is the main mechanism is hypokalemia for TPP. But normokalemic, it is described classically as a part of channelopathies, both normokalemic, hypokalemic, and hyperkalemic.
Yeah, what is Eaton-Lambert syndrome?
Ma'am, it is a paraneoplastic weakness, which mimics myasthenia gravis, but usually it is antibodies against the calcium receptor, ryanodine calcium receptor.
So can you continue with the other differentials?
Yes, ma'am. Ma'am, rapid correction of free hormones, it has been recently reported to present as a proximal myopathy. But that is rare incidence with very few reports, which has been explained as a rapid decrease in this free hormones. It leads to a state of relative hypothyroidism that alters the T3 equilibrium, intracellular intramyocyte T3 equilibrium, which leads to myocyte injury, and this is characterized by elevated creatine kinase levels. So we can consider this in this patient as a differential, as we know that patient was off therapy and recently for last 3 weeks has started therapy, but creatine kinase was normal, ma'am, and this incidence is also not that, it's very rare. And apart from that, acute exacerbation of any thyrotoxic myopathy. Thyrotoxic myopathy is usually a slowly progressive process, and an acute exacerbation or trigger is especially a thyroid storm. But this patient was clinically not thyrotoxic, and but still it can be held as a differential considering the clinical presentation. And Basileus paraplegia, it is this presentation is mirror image, absolutely similar with the reflexive paralysis, pairing the sphincters and with no sensory deficit. But it is some have described it as a thyrotoxic neuropathy or idiopathic neuritis, and AIDP is the same presentation, but the improvement is seen after IVIG, whereas in bacillus paraplegia, it responds after treatment of the thyrotoxicosis. And then polymyositis was also differential, but it is last in the line of differential because it will present similarly as just a muscular weakness, but the progression is usually subacute from weeks to months. But since it is also a differential diagnosis of predominantly proximal weakness, so I kept it as a differential diagnosis.
So how long have you had the patient in follow-up?
Ma'am, it's been just 4 weeks.
4 weeks. So how long would you like to follow up and then, be able to tell how well the patient has responded?
I'm considering the progression, the natural history of AIDP. After 2 weeks of a prodromal viral illness, the weakness starts, but it becomes, after 2 weeks of in progression of the weakness, it becomes static for 3 weeks. And within the next 2 weeks to 6 months, 80% of the patients, they recover. And since the patient has had a good response to IVIG, then we can expect that his muscular weakness will improve.
But with the 8 weeks, 12 weeks?
Ma'am, we will should improve by 6 to 8 weeks, but we will follow up for at least 6 months.
Yeah, 6 months, sometimes even up to 12 months it might take. But whatever is left after 12 months is unlikely to recover.
Yes, ma'am.
6 months is a fair time to observe. Okay. Dr. Patwardhan?
I just wanted to ask, have you seen any polyneuropathy in toxic multinodular?
Sir, I have not seen.
Because thyrotoxicosis as such presents mainly with myopathy rather than neuropathy. So you must have seen proximal weakness in patients who have severe weight loss, etc. But specifically polyneuropathy, demyelinating, proved by EMG. Have you done albuminocytological dissociation also?
For this patient, no, sir, we have not done it. Ideally, the albuminocytological dissociation, if you do it as early as 7 days, the chance of getting a positive report is low. At least we should wait for 2 weeks to see that. But sir, we had not been able to do it. By the time we detected, within 10 days, we transferred the patient to neurology department.
Nerve conduction?
Yes, ma'am. We had done nerve conduction, which revealed a demyelinating polyneuropathy.
There are actually antibodies, isn't it, which can be measured, and you can predict the course or prognosis of the patient.
Yes, sir. So anti-ganglioside GQ1, some of the. So that is also described some of the factors that associate AIDP with Graves' disease. Is this common gangliosides are common to both thyroid follicular cells as well as the neuronal cells. Apart from that, also there is increase in the intracellular adhesion molecules in Graves' disease, and this is associated also. This increase is also seen in GBS. And then the genetic and environmental factors like molecular mimicry between the bacterial epitopes and the TSH and neuronal epitopes. This theory has been given to associate AIDP with Graves' disease.
Not related to this patient as such, but have you seen myasthenia gravis in Graves' disease?
Yes, sir. I've seen. So just
Have
recently,
you had any thymoma which needed?
Sir, hypo? Pardon, sir?
Any patient with thymoma actually presenting with? I remember 2-3 patients who needed surgery also because of thymomas. But not very common, but one should remember that myasthenia also is part of Graves' disease. This, as I was saying, bulbar paresis, this presents very dramatically. And at that time, we didn't have IVIG or anything. So we just waited by putting the Ryle's tube and allowing the patient to recover after thyrotoxicosis. But they recover fully.
I think that is very gratifying. The recovery, what you are describing.
Definitely.
Yeah. Pramila is with us. Pramila Mini. You are mute.
Yeah, I'm there, ma'am.
Yeah, yeah.
Only thing is for the thyrotoxic periodic paralysis, most of the times they'll have hypokalemia, but if you see in literature, there are few isolated case reports with normokalemia also reported. So that's also important because not having hypokalemia is not just a thing to rule out. Sometimes rarely they can present. It's rare, but they can present with normokalemia as well. So that's also very important to know. But that's a rare presentation.
Have you
And-
published this or are you planning to publish it?
I'm planning to, ma'am. It's just a month back the patient had come. So
Okay.
we've kept all records.
So I think Pramila will tell you where to publish. In our
Yeah, we have our Thyroid Society journal, Thyroid Research and Practice. You can send to that because we accept case reports and full text articles and invited reviews, but case reports and full text are acceptable. You can send it and we can send it for peer review.
Sure, ma'am. We'll do it.
You were saying something else, Pramila?
No, ma'am, nothing.
Okay. So then we can go over to the quiz. Ganvi?
Ma'am, there are a few questions, I think.
In the chat box, there are a few questions.
Dr. Patwardhan, we have the questions in the chat box.
Cannot see.
Yeah. One is answered, one is showing as answered. The first, I'll read out. The first question is, how can carbohydrate be an aggravating factor in this case? So Dr. Ipshita has answered few of the things. The resident, Dr. Swikriti, can tell why carb intake. This is a very important question because why carb intake aggravates the paralysis? Because that's one of the pathophysiology.
The periodic paralysis is it's explained due to the accentuation of sodium potassium ATPase apart from defects in the KIR 2.6 and increase in catecholamines and increase in insulin. Both of these are the underlying factors for accentuating the sodium potassium ATPase channel. So that is how high carbohydrate intake will lead to increase in the insulin release, and that will aggravate the hypokalemia and the periodic paralysis. And exercise will increase catecholamines. So these are the triggering factors.
And also hyperinsulinemia has been seen in acute attack of TPP. When people have tried to check the insulin levels, they have found that insulin levels are higher at that time. And also that is also one of the things which is seen. So that is why they say that insulin participates majorly in the pathophysiology of hypokalemia and TPP. There are two more questions, I think.
Extracellular to intracellular shift of potassium depends on insulin levels mainly. It is associated with GLUT2 or GLUT4 activity. So when your glucose is going inside the cell, it takes the potassium also with it. Usually the idiopathic hypokalemic periodic paralysis are precipitated by high carbohydrate diets, isn't it? Anybody else?
There are 2-3 more questions, I think.
Let's do that.
The other question is, was there an autoimmune phenomena in the Graves' disease with neuropathy? So they can tell. The Dr. Amod has asked that, was there an autoimmune phenomena? I think this has been partly discussed. We have discussed it. If anything, Dr. Ipshita, you want to add, or we can go ahead?
Definitely, there is a correlation of autoimmune association not only with Graves but the spectrum of Hashimoto's disease. So it has been proven, and some various reviews has been done where they've seen that both not only AIDP but also CIDP has been associated with increased prevalence, but AIDP being relatively less. So this is a spectrum of autoimmune disease, and as Swikriti has already told, probability of the ganglioside antibodies, which are common to both the thyroid follicular cells and the neuronal cells, the theory coexists with that. But however, these cases are not very common, only hardly reported number of them are there.
True. So he has also asked that, was there any involvement of the laryngeal nerve?
No, for this patient, there was no involvement of the laryngeal
there was
nerve.
no. Yeah,
there was no involvement.
Yeah. And he's also asked that will steroids help instead of IVIG? Two people have asked the same question, like, will steroids help?
Swikriti can take this up, otherwise I'll take this up.
Yeah, Swikriti, you want to take this up? I think Swikriti is locked out. Ah, she's there. Yeah.
There she's there.
Ma'am, in these conditions, IVIG and plasmapheresis have been tried because acute in AIDP also we don't try steroids. It's usually given in CIDP. But if it can be tried, ma'am, but it's not been tried.
Yeah,
So
they
since,
are.
since the presentation has been acute with the features of whatever was there in the NCA, so definitely it was an acute one, AIDP. And definitely the immunobenefit is more exploited with the IVIG rather than the steroids. So as per the neurologist, we did ask them that though the progression has been beyond 7 days, what is the advantage? But they said that since the upper limb has become involved, not necessarily that further progression will not occur. It may involve the bulbar muscles. So that was their cause for which they indicated, and they said that no, we'll go for IVIGGs. And CIDP, more of plasmapheresis, can give a improvement if you're dealing with a CIDP where the progression is beyond 3 or 6 months of weakness.
I think, Dr. Gandhi, we have finished the questions. Most of the questions have been answered, I think.
Yes, ma'am.
Anything else is left? You can see, then we can take that up.
It's answered, ma'am. There is one more thing. Everything has been answered.
Yeah, it's just a remark. I think the questions are done, I think.
Yeah, I think we should now move on because 40 minutes are up. And I think the quiz, time for the quiz.
Yes.
And then the second.
Yes. Over to you, Gandhi.
Yes, ma'am. Thank you, Dr. Sarita ma'am, Dr. Pramila ma'am, Dr. Patwardhan sir, Dr. Ipshita, and Dr. Swikriti for this absorbing discussion. So now we will have the quiz, which is the next upcoming session. Dr. Ipshita, I would like you to introduce the quiz master for today's session, Dr. Arun Kumar sir.
Yeah. So the quiz will be by Dr. Arun Kumar Pandey, who is the Director Endocrinologist of Lucknow Endocrine Diabetes and Thyroid Center. He has done his DM from SGPGI Lucknow, and his area of interest is managing endocrine cases in resource-deficient settings, dealing with monogenic diabetes, sports endocrinology, and community endocrinologies. He has got multiple credits to his achievements. He had got the best case report at the 30th A.V. Gandhi Awards and various other awards. So so I invite him to further take over the quiz and start the quiz.
Yeah.
Before we start the session, shall we?
I think we have discussed the rules of quiz. Dr. Gandhi had already told that.
Yeah. Ma'am, should we discuss it again, Dr. Sarita ma'am?
Beg your pardon, regarding the...
Should we display the quiz
rules, ma'am?
Yes, please. Yes, please.
Yeah, just before we discuss, for the reason that some people might have joined now, so that's why.
Right.
Yeah.
So the quiz participation rules: to participate in quiz, having a Zoom app on your mobile device or laptop is essential. You're requested to use a laptop for the ease of experience. The quiz will run for about 10 minutes. There'll be first 2 dummy questions followed by the actual quiz. The quiz master will display the case or description by screen sharing a PowerPoint file. The participants should use the polls option to participate in the quiz. All 10 questions will be available when the poll is launched, and answer for all the questions should be submitted at once at the end of 10 minutes. To read the case or description, you can close the polls option using the X button and again use the polls option to answer the respective question. So before we start, we'll have the 2 dummy questions. The IT team, please display the dummy questions.
Yes, ma'am. Just.
Yeah. So the first dummy question: in which city is Taj Mahal located? Option A, Chennai, option B, Mumbai, option C, Agra, and option D, Bangalore. So going on to the second dummy question: how many oceans are there? Option A, 8, option B, 5, option C, 6, and option D, 7. Hope all the participants could enter their answers. So over to Arun Kumar sir to start the quiz.
Thank you very much, Dr. Ipshita and Gandhi, to make my job easier. So is my voice audible?
Yes, sir.
Yes.
So I'll share my screen. I cannot. I'll just unshare and share it again. So is the slide visible?
Yes, sir.
Yeah. Sorry for that. I thought I'll present it directly from the Google Drive, but it was not allowing me to present from there. So coming to a case, this is a 35-year-old female presented with symptoms suggestive of thyrotoxicosis for last 2-3 weeks. The palpation of thyroid revealed that it was non-tender diffuse enlargement of the left lobe with no definite nodule. Her thyroid function showed a raised T3 and T4. TSH was suppressed. TSH receptor antibody was 2.4. The ultrasound thyroid was done twice to see whether there was any nodule in the thyroid. It was non-nodular, enlarged, heterogeneous left lobe, whereas the right lobe was normal. It appeared homogeneous. So this was her thyroid scan, which showed predominantly the uptake on the left lobe of the thyroid. So what is the differential diagnosis? What is the diagnosis for this patient? Autonomous functioning thyroid nodule, Graves' disease with cold nodule, unilateral Graves' disease, thyroid hemigenesis, Graves' disease with hot nodule. So the next question is, all of the below is the management for unilateral Graves' disease except hemithyrectomy, radioactive iodine, medical therapy, and lithium. Then the next question is, all of the statements are correct except in the growth plate, hypothyroidism leads to growth arrest, epiphyseal dysgenesis, delayed bone age, trunk is disproportionately short in relation to the limb cartilage, growth is unaffected. The changes result in low bone turnover and overall gain in bone mass and mineralization in prolonged hypothyroidism. Despite normal bone density in newly diagnosed hypothyroidism, there are at high risk of fracture. So the question is, all of the statements are correct except. So the differential diagnosis for raised TSH, normal T4 and T3 includes macro TSH, TBG deficiency, TBG excess, all the types of thyroid hormone resistance. So we will be having the answer at the end of the question, ma'am.
Yes, sir.
Yeah. So now coming to the question 5, a 54-year-old woman with surgical hypothyroidism, type 2 diabetes is referred for progressive increase in levothyroxine dosage required over past 12 months. Other medication include metformin, lisinopril, aspirin. She acknowledges that some recent weight gain is there, but she reports that strict adherence to therapeutic regimen takes no over-the-counter preparation. On examination, her blood pressure is 140/88. She has no palpable tissue in the thyroid bed, normal deep tendon reflex, moderately lower extremity edema. Her TSH is 8.7, T4 is 1 nanogram, free T4 is 1 nanogram per deciliter, then total cholesterol is 305 milligram per deciliter, triglyceride is 880 milligram per deciliter, albumin is 2.6, HbA1c is 7.1, urine analysis shows a protein of 2.2 grams per gram of creatine. So which of the following is the most likely cause of patient increasing the levothyroxine dosage? 1, the metformin therapy, medication non-adherence, celiac disease, euthyroid sick syndrome, then nephrotic syndrome. Coming to the sixth question, following can cause periodic paralysis with thyroid disease, Graves disease, thyroiditis, toxic MNG, all of the above, 1 and 3. A patient of lung carcinoma on therapy for same shows TSS suppress, raised T4 and T3. The cause of this is immunotherapy-induced thyroiditis, sick euthyroid syndrome, Graves' disease, and hypophysitis. So question number 9 is for the thyroxine supplementation, BMD statement incorrect is there is the reduction in BMD in patients on suppressive doses of LT4. Suppressive levothyroxine therapy causes significant bone loss in postmenopausal women at the lumbar spine and hip, but not significant effect on premenopausal women or men. Trabecular bone was reduced more than cortical bone. Osteoporosis prevention with bisphosphonate should be considered in this patient. So another question, this is the 10th question. 65-year female, known case of primary hypothyroidism. She came with history of recurrent hypokalemia. She is non-hypertensive. Her serum potassium is 1.8. Urine potassium is 28.9 mole per gram of creatine. TTKG is 5.5. She is having metabolic alkalosis. Urinary chloride is 313 millimole per gram of creatine. And urine calcium, sorry, this this is urine calcium, which is 14 mole per gram of creatine. So the options, what is the diagnosis of this patient based on this biochemical parameter? Distal RTA, proximal RTA, Bartter syndrome, or Conn syndrome? So this is the end of the quiz.
Thank you, sir.
So we'll have the answers after the second case, right?
Yes, ma'am. The answers will be discussed following the second case presentation, and the winner will be announced post-discussion.
Absolutely. So we are going there.
Yes, ma'am.
Continue.
So now we will have the second case discussion that I request Dr. Patwardhan sir and Dr. Amrita Pradhan to take over the second case.
Yes, thank you.
Yes.
So with these interesting questions, people are busy thinking about it. Second case will be presented by Dr. Pradhan, and it is about thyroid-associated orbitopathy in a patient with hypothyroidism. It is also interesting presentation, and we do see sometimes hypothyroid patients, sometimes thyroiditis patients, sometimes even totally euthyroid patients coming with thyroid-associated or thyroid autoimmune orbitopathy. So it's good to discuss it and what are the general policies to investigate and management. May I request Dr. Pradhan? Amrita?
Yes, sir. Sir, I'm present. Sir. Esteemed panelist and audience, today I will present this case.
Can I take a moment? I think the 8th question was not displayed. Can I display that question?
Asmita, can you clarify?
Hello.
Asmita,
Hello.
Yeah, tell me.
I have cross-checked it. The 8th question was not displayed, ma'am.
So 8th question is unilateral Graves is most common which slide?
This was not displayed while presenting.
Yes, sir, but it's in Zoom panel poll.
Anyway, the whatever it is, it's fair for everybody, isn't it?
Yeah, ma'am.
Yes.
It was, if
Yes,
it was not displayed, it was not displayed for everybody. So it doesn't matter. So the it will be out of 9. So don't worry about that. But when you are explaining, you can give answer to that also. So that at least people, it's a learning experience.
Okay, ma'am. Okay.
Is that all right?
Ma'am. Yeah.
We'll go ahead. We'll go ahead. We won't go back again.
Yeah, ma'am.
Thank you.
Hello.
Yes, ma'am, I'm sharing.
But we saw your screen, but we can't see it now.
Ma'am.
Put it on slideshow mode. The fifth option in menu bar. Hello.
Yeah, we can hear Amrita.
Yes,
We
ma'am.
can
Yes,
hear
ma'am.
you.
Yeah,
We'll
ma'am.
make it slideshow.
Ma'am, actually, I cannot make it. That is the problem.
The bottom, where the bottom, you have three options. Like first is view.
What I'll suggest, sometimes this happens with Zoom. Better to share the whole screen rather than just the PPT. This
Let
happens
her
when some,
continue like this if she's confused.
Yes. So just, ma'am, just in your bottom, there is a three options. View, the above 58. Hello.
The one that looks like a wine
Hello?
glass. The one that looks like a wine glass is slideshow.
And just below the 58% of your page. Just
Just next to the 58%.
No, ma'am, I can't.
Okay, go
fifth
ahead.
option.
Let her continue like this, please. Please continue, Amrita.
Yes, ma'am. Yes, ma'am. I'm continuing. Respected panelists and audience, today I will present this interesting case, that is primary hypothyroidism presenting with clinically active moderate thyroid associated ophthalmopathy. So here, this patient, 33-year-old male, he presented with the chief complaint of swelling over anterior aspect of neck. Swelling over the anterior aspect of neck noticed since 2 to 3 months, and protrusion of both eyes 1.5 month
Your
back.
slide is not
1.5.
moving. Your slide is not moving.
he has to
Ma'am,
unshare
now?
and share the whole screen rather than just Microsoft. Select the whole screen while you're sharing.
You stop sharing and then go back. Are you trying to understand?
Yeah, share the whole screen rather than Microsoft, this PPT.
Just click on share screen and the very first option.
Is
Ma'am, now
Sweekriti
is
with
it?
you? Is Sweekriti with you?
No, ma'am.
No, ma'am, she's at a different place. I've just asked her to go to and help her out.
Hello. Just click on share and very first option is screen. Just click on that screen. First option. The entire screen.
Entire screen.
Yeah.
Ma'am, is this? Ma'am, can you see the screen?
No, we cannot.
First slide, that's all.
Yeah, we can see first slide. No, what you do is do the slide show in that screen only. Now, when you go to the whole screen, up there is a slideshow. Click on that. There also you can put the slideshow. Then it will move. You first share the screen. Green button is there now down on the screen. With that, share. There is a green button down.
Amrita, in the down
Yes,
to
ma'am.
in the green button with
Yeah. It's
yes,
coming
yes.
now. It's coming. Cool down. It's coming. It's okay. No issues.
From beginning, you can choose if the current slide is not allowed.
Yeah.
Respected panelist and audience, I will be presenting this case, that is primary hypothyroidism presenting with clinically active moderate thyroid associated ophthalmopathy. So this is a 33 years old male who presented with the chief complaint of swelling over anterior aspect of neck noticed since 2 to 3 months and protrusion of both eyes 1.5 month. So this patient, he noticed swelling over anterior aspect of neck.
Sorry to disturb.
Since
Is
last 2
everybody
to
able
3
to
months.
see the screen?
And it
is screen showing up for everyone?
No, ma'am. No.
Better not to do better not go to full screen, just present it right from there.
It's nothing, nothing is showing up. Screen is not showing up. It's just showing started.
Okay, okay, ma'am.
Otherwise, Amrita, you can mail it to me immediately, then I'll just share it from my end quickly.
You can mail it to
Okay, ma'am.
Dr. Ipsita.
Quick.
She can share. Yeah. That you can do.
Okay, ma'am.
Now, dear panelists, while this is going on, I'll share just my experience with one patient recently. She came from nearby, you can say, city, and said that her eyes have been protruded, and she is taking treatment for thyrotoxicosis also. Thyroid is under control. Am I audible?
Ma'am,
Thyroid is under control, and somebody had even asked them to stop neomercazole, but the eyes had become disproportionately proptotic, and one of the eye was losing vision. Patient was euthyroid by the time they had come to us, and he already was taking a lot of steroids, and there was proptosis. Some people were treating him, I think, with intraocular steroids also. Unfortunately, all the investigations apart from this, trying to find out any local cause, but it was a bilateral, even though it was asymmetrical, and patient was not responding at all. In between attempts, to overdose him with antithyroid drugs had actually worsened the situation as expected. So somehow he was not responding to steroid, and question was what to do. His CRP was about 67, and rheumatoid factor was positive. He gave history of rheumatoid arthritis, which was quiescent. Is it okay? Sharing? Okay, I can stop my narration. This patient ultimately responded to methotrexate and hydroxychloroquine. So if now you can start showing your slides, Amrita.
Yes, sir. Yes, sir. I'm doing it right now. Just wait. Amrita, you just stop sharing. I'll share it from my end.
Ma'am, I'm doing that. I'm just.
Right. Right. I think we're able to see.
Yes.
So go ahead.
I'll be presenting this case of primary hypothyroidism who presented with clinically active moderate thyroid-associated ophthalmopathy. So he's a 33 years old. Ma'am, next slide.
Yes.
So he's a 33 years old male who presented with a chief complaint of swelling over anterior aspect of neck, noticed since 2 to 3 months, and protrusion of both thighs 1.5 months back. So patient noticed swelling over anterior aspect of neck since last 2 to 3 months. It was not associated with any pain, sudden change in size, dysphagia, dysphonia, or hoarseness of voice. There was no history of weight loss, tremulousness, heat intolerance, excessive sweating, increased frequency of stool, or change in appetite. Rather, there were non-specific complaints of aches and pains and lethargy, and there is no history of weight gain or cold intolerance. Next slide.
It's not moving. Just a second. I'll quick. Understand what is happening.
Click on toes twice.
Yes. Yes.
Yes.
Yes. Go ahead. I think we are the next slide.
So the patient also noticed protrusion of eyes, initially in right eye, which has gradually increased over the course of time, and subsequently also involved the left eye. It was associated with grittiness, lacrimation, and foreign body sensation. Also, it was associated with redness of both eyes and gradual increase in protrusion of eyeballs, which is he noticed 2 weeks prior presenting to us. It was associated with a dull aching pain, which was predominantly behind the eyes and increased during movement. There was also a history of double vision, which was initially occasional, but with time it increased and now present in all direction of gazes. So 2 months prior to presenting to us, patient was evaluated outside, during which he was diagnosed with hypothyroidism and was started on levothyroxine supplementation. He was compliant to therapy. Patient was not had not appreciated any neck pain prior to the onset of this hypothyroidism, and he was a known smoker for 12 years and still continuing. So coming examination, the height is 164 centimeter with weight of 57 kg, BMI of 21.1 kg per meter square, waist circumference of 78 centimeter, hip circumference of 84 centimeter with waist hip ratio of 0.9. Pulse rate is 82 per minute regular. Respiratory rate is 15 per minute with thoracoabdominal. Blood pressure is 128 by 80 mm mercury in right arm supine position with temperature of 97.6 degree Fahrenheit. There is no pallor, icterus, cyanosis, clubbing or pedal edema. JVP is not raised and there is presence of thyromegaly. On neck examination, inspection, there is a grade 2 diffuse goiter of approximate size of 10 into 7 centimeter, which is symmetrical and moves with deglutition with overlying skin normal. On palpation, there is a 10 into 8 centimeter size goiter with film consistency, smooth surface, non-tender, 2 nodules palpable at the lower lobe, no lymph nodes palpable, lower border delineable, and neck circumference of 38 centimeter. There is no thrill palpable or bruit hurt. Coming to the examination of the eye, there is presence of eyelid edema, eyelid redness, conjunctival redness, pain on movement, pain at rest, with the absence of conjunctival edema or caruncle swelling, with a CAS score of 5/7 in the right eye, and there's presence of eyelid edema, eyelid redness, conjunctival redness, and pain on movement, both at rest, with absence of conjunctival edema and caruncle swelling in the left eye, with CAS score of 5/7 in the left eye. Proptosis was measured with Hertz exophthalmometer, which was 25 mm in both the eyes. Visual acuity was 6/6 with preserved color vision, with both direct and indirect light reflexes present, and fundoscopy being normal. Coming to the systemic examination, the higher function were normal with first cranial nerve intact. Visual acuity was 6/6 in both the eyes with preserved color vision, and field of vision was restricted but doesn't coincide with the examiner. And there was no RAPD. Then third, fourth, and sixth cranial nerve, that was restricted movements in all directions, both the eyes, and there was binocular diplopia with Gorman score 3. Other cranial nerves were intact. Motor system bulk tone normal with power of 5/5 across all joints, and deep tender reflexes were normal with plantar bilateral flexor. Sensory system were intact with no cerebral signs. Skull and spine were normal. CVS examination was normal with apex invisible at left fifth intercostal space, half inch inside the mid-clavicular line with normal S1, S2 and no murmur. Respiratory system had a bilateral chest symmetrical with trachea midline, normal vesicular breath sounds, no added sounds, and per abdomen examination were normal. So he's 33-year-old male, diagnosed case of primary hypothyroidism. He presented with swelling of over an anterior aspect of neck noticed since 2 to 3 months, which was associated with protrusion of both eye for 1.5 MAC, which was worsened over 1 to 2 weeks. He is a known smoker. On examination, he had a BMI of 21.1 kg per meter square, grade 2 goiter, CAS clinical activity score of 5/7 in the right eye and 5/7 in the left eye, with Hugo severity of moderate to severe. So routine investigation were within normal limit with CBC and CPS showing normal smears. So sodium potassium 138 and 4.6, and fasting PGPG of 18 112. Calcium profile were within normal limit, and leptin lipid profile were within normal limit. So the baseline TSH was 48 with FT3 of the 1.8 and FT4 of 0.32. Currently, the patient is euthyroid with a TSH of 0.54 and FT3 of 5.6 and FT4 of 1.12. We did anti-TPO antibody, which was 600 international units per liter. We did an ultrasonography, which has mild heterogeneous parenchyma with multiple hypoepic nodules, and a TSH receptor antibody, which was less than 4 international units, which was 40 international units per liter. So to rule out other etiologies, we did a NCCT orbit, where we found the distance of the anterior surface of globe from interzygomatic line of more than 23 mm in both eyes. There is bilateral symmetrical enlargement of ocular muscles with increase in the retroocular orbital fat. Next. So the diagnosis of this patient is primary hypothyroidism, autoimmune, with thyroid-associated orbitopathy, with a clinical activity score of 5/7 in the left eye, 5/7 in the right eye, and the Yugoco severity score of moderate to severe. So we, after making a diagnosis of thyroid-associated ophthalmopathy, we asked the patient for smoking cessation. We gave methylcellulose eye drops and tapes for closure. We continued the treatment with levothyroxine 100 microgram 1 tab OD 1 hour before breakfast. And for as the clinical activity score was more than 3/7, we gave a pulse intravenous methylprednisolone dose. We went with the 4.5 grams dose with injection methylprednisolone 500 milligram weekly for 6 weeks. As there was no progression of the disease, so we continued with this management and completed total 12 weeks of 500 milligram weekly for 6 weeks, followed by 250 milligram weekly for 6 weeks. So this is the follow-up image after 3 months, and there was ma'am, previous slide. This is the follow-up image after 3 months. There was an improvement in the conjunctival redness, eyelid redness, gaze-evoked pain and spontaneous pain and diplopia with a CASH of 3/10. Next. So I would conclude my case with a review of literature. Hypothyroid thyroid eye disease was first reported by Weiss et al. In 1968. Since then, it has been there have been other reports on hypothyroid thyroid eye disease, and it has modified the concept that hyperthyroidism is an essential component of thyroid eye disease. Rarely, thyroid eye disease occurs in euthyroid patient or in those with history of chronic autoimmune thyroiditis. And they have seen that in this thyroid eye disease is almost always seen in conjunction with the circulating TSH receptor antibody. Next slide. So here it is a paper which has been published in 2016 JCEM. Here they have found that all the hypothyroid patients had increased anti-TPO antibodies. Most of them had heterogeneous ultrasonographic imaging pattern, with vast majority of them being euthyroid and hypothyroid. They also found that thyroid stimulating antibody were strongly associated with thyroid-associated orbitopathy in Hashimoto thyroiditis, and they may be contributing to the pathophysiology of thyroid-associated orbitopathy. Thank you.
Thank you, Amrita. It was a good presentation. Do you want to make it open, or do you want to have some more comments? Okay, I'll make the case open.
Yes, sir.
Yeah, Dr. Sarit. Do you want to say something, Mishra? I thought you were saying something, but you were muted.
So myself?
Huh?
No, sir. I just said that we can make the case discussion with Bajaj Madam's comments to begin.
Definitely. We'll ask her definitely. Sarita? You are muted. You are muted, ma'am.
Sorry. I think this happens invariably. So I think that was again a very good case. What is hashitoxicosis?
Hashitoxicosis is a Ma'am, there's a fluctuation between hypothyroidism and hyperthyroidism, depending upon the blocking antibodies and the stimulating antibodies. Ma'am, there's a fluctuation between these antibodies, so that is hashitoxicosis.
Yeah. So clinically, how will the patient manifest? And I mean, how will you follow up? What investigations will you do? Which are the investigations that you need to monitor?
Ma'am, clinically, they may have episodic hypothyroidism with after some months of follow-up of hyperthyroidism. So we should regularly follow up them with FT3 thyroid profile and have a regular follow-up.
Yeah, but would you need to repeat antibodies also, or antibodies like initially?
Ma'am, if
the basic follow-up,
we need to repeat. We need to, ma'am, we need to repeat TPO TSH receptor antibodies and TPO antibodies.
Okay. So you've said the thyroid eye disease per se,
Yes.
you can have it. It can precede Graves' disease. I'm talking.
Yes, ma'am. It can precede.
Scenario here. Yours is hypothyroidism presenting with thyroid eye disease, right?
Yes,
How
ma'am.
common is that? How common is thyroid eye disease with Graves classical Graves? Preceding, you can have Graves of thalmopathy preceding Graves, right? It can start off with the onset of Graves. You understand what I'm trying to ask?
Yes, ma'am. Ma'am, 75% Graves disease is associated with Graves ophthalmopathy, but in 20%, 10 to 15%, it may precede the Graves disease.
By several years. It's not just, by years. It doesn't have to be, it's not even months, it's several years, right? Okay.
Yes,
and what you are describing, is it published in the literature? You showed one JCM publication. There must be case reports.
Yes, ma'am. Ma'am, it is a ma'am, this is a publication, ma'am. This is a 2016 JCM publication where they have seen hypothyroid patient who they took the hypothyroid patients and they measured thyroid stimulating antibodies in them. Those who developed thyroid disease, they had thyroid stimulating antibodies and they had overt thyroid eye disease, but antibodies were absent in those who did not have thyroid eye disease. And these all hypothyroid patients, they were confirmed with anti-TPO antibodies and ultrasonographic features of heterogeneous imaging. And majority of them, when they had developed ophthalmopathy, they were either euthyroid or hypothyroid.
I think what Sarita is trying to ask is, were these patients previously thyrotoxic? They became hypothyroid, but their eye disease came up later on. Before they become fibrotic, they become hypothyroid, they still can harbor anti-TSH receptor antibodies.
So they in this paper, they had. So in that paper, they had taken only those patients who were biochemically hypothyroid, without any previous history. No, without any previous history of thyrotoxicosis.
Why they were not presenting with thyroid receptor antibodies were positive. They were blocking antibodies.
So I cannot.
So I had also gone through that paper.
So they found
the data of
so I could not hear the question.
Hold on, Amrita. I'm just replying to sir.
So I could not hear the question.
Okay.
Hold on. I'm just telling to sir. Sir, I had also gone through that paper. So it included 200 patients who were frankly hypothyroid.
So I could not hear the question.
Amrita, can you just be quiet, please?
Okay, sir. Okay,
so that paper included 200 patients of hypothyroidism, and all of them were overtly hypothyroid with a mean TSH beyond 40. So from that 200 data, they found that 6 to 9% of them, they had involvement of tau, from which around of those 6 to 9%, 2/3 were having mild and 1/3 were having severe degree of tau. Those who were having severe degree of tau, they found that the risk factor was their older age and those who had risk factors of smoking. And there was no sex predilection between those who were having severe variety of tau in the hypothyroid group. They had also taken a comparison of the Graves patient also in that, who were frankly hyperthyroid, Graves disease, sir. And in the hypothyroid patients, they did a bioassay of the TSH receptor antibodies because they wanted to know whether it is neutral or blocking or stimulating ones. And they found that in all the 6 to 9% of those hypothyroid patients who had any form of tau, all had evidence of TSH stimulating antibodies as per the bioassays. And they found that
I was interested in,
Sir.
Was there any history of previous thyroid toxicosis?
No, sir. No, sir. No, sir.
No.
In those patients, sir.
But then what is the explanation that there was stimulating antibody which clinically never presented with thyroid toxicosis?
That was that, and they have given that, sir. In the discussion part, sir, they have written that probably it is these TSH stimulating antibodies at the level of the orbital fibroblast, which is probably causing the protrusion and the tau. They have given that in the discussion, and they have also written the limitation why they could not explain that how come these patients did not have features of hyperthyroidism but had evidence of tau.
Okay. This remains a puzzle.
Yes, sir. It's a very beautiful publication. Even I was also surprised, but that's what they have written, sir.
Interesting.
So can I ask a question to Dr. Amrita? What are the components of clinical activity score?
So the components of clinical activity score is the spontaneous pain, gaze-evoked pain, eyelid swelling, caruncle swelling, and there is redness, eyelid redness, conjunctival redness, and
conjunctival edema.
Edema.
There are two pains, 2 redness, and 3 edemas.
3 edemas.
Yeah. But one of the slides you said score 3 by 10. So be careful when you present.
Sir, actually, it is after 3 months. After 3 months, I have done the cash 10 score, sir. I have added the other 3 components like Snell's chart 2 and eye adduction, and those 3 components I've added, and I have written 3 by 10, sir.
And I think the recent UO guidelines now says is to give 750 milligrams of methylprednisolone right away. Or when we are giving 500 milligrams, we should give mycophenolate mifetil.
So that is present in the UGOGO 2021 guidelines. Yeah. But I had seen the thyroid ATA guidelines of 2022. So they have written the first line is giving IV glucocorticoids, and second line acceptable is giving radiotherapy along with IV glucocorticoids. And if the patient has more of proptosis and diplopia, we can go for other options like peptotumab will be better, but not available.
No, but the dose
so
of methylprednisolone.
So 4.5 grams and 7.5 grams. 7.5 grams is those who have a worse outcome we can give, and also it has better profile as compared to 4.5, but with more side effects. So we went on the safer side and we gave 4.5 grams. And as the patient was doing better, we were monitoring every weekly, and there was no worsening of diplopia. So we continued with this regimen.
But I think the UGOGO, this is probably considered to be one of the best. So they say 750 to be given weekly. And ultimately, we have to go for 4.5 gram, not more than that. But to start with, they have given a reference of a study wherein they compared giving 500 milligram and 750 milligram. And when they saw was that remission was better with 750 milligram. And they ultimately, the maximum dose was same 4.5 and 8 grams, not more than that. But they recommend to start with 750, or when this 500 is given, better to give mycophenolate mifetil. Many times when we struggle after 6 or 8 weeks, what to do then? So probably, I think that's the reason why they have said 750 would be the starting dose.
Bolus dose.
Yeah.
I think you are right in the sense that it becomes very difficult after 3 to 4 months as to what to do with these people.
Yes, sir. So
I was trying to tell one patient, not a hypothyroid, thyrotoxic patient, who had history of rheumatoid arthritis and was apparently in remission, had this Graves' disease, ophthalmopathy, initially responded to methylprednisolone, but later on stopped, became refractory, and
He's frozen.
And he responded to methotrexate plus HCQS even at eye level. So that was something which was very interesting to me. In one case only, I had taken course to give retrobulbar radiation long ago. This was a who was about to be married and was not getting, yes, it's a cosmetic problem. So we took a chance and gave 5 sittings of retrobulbar radiotherapy, and it worked like a miracle, I tell you. Within 6 weeks, she was looking normal. She got married. She has 2 children. Now her daughter has got Graves' disease. She comes with daughter. Luckily, daughter doesn't have eye disease. But this is just for follow-up.
Thank you. So we can go over to the quiz answers now.
Yes. Yeah, ma'am.
Dr. Patwardhan.
Oh, yes, definitely. So if everybody is not having any question in the chat box,
Of course, there are a lot of questions there. I think we always forget.
I think then they will discuss personally or email us something. Okay, we can, because time is running short. Can we go to the answers of the quiz, Arun?
Yes, sir. I think one of the question was for mycophenolate mofetil.
Yeah, why was it not given? So I think,
Yeah.
would you like to, I think we should take those questions. I think that's important.
Yeah. So I think it is again by Dr. Amrita. Is she going to take that now?
Why mycophenolate mofetil was not given?
Ma'am, this is a case of almost 1 year back. So at that time, we were not in touch with his guidelines, ma'am. That time we had given according to the.
If you
book
don't
and
mind,
also
I'll take up that question.
Yeah.
Actually, ma'am, when the patient came to us at that point, I was very confused because it was a hypothyroidism and we had done a quantitative trap. So we had not done a bioassay. So I was not very sure whether the other drugs which has come for managing tau in hyperthyroidism, can we try that or can we not try that? So mycophenolate mofetil, definitely for Graves related tau, it's there. But I was not very sure whether I should give for this patient or not for this patient. So when I saw the response to after 2 doses of 500 milligram, when his cash came down and there was improvement in diplopia, I just said that let me wait. And when I did a research review of literature, I didn't get any data for use of MMF in a hypothyroid associated clinically active tau. So I was in double mind. So I just said that let us see. And we have completed the steroid doses and it's been almost 7-8 months post his steroid injectable therapy and it has been static. We have not repeated the TSH receptor antibodies again to see whether there is a quantitative decrement because of monetary constraints, because it's cost around 4,000 rupees, not available in the institute. So that was only once on request, the patient agreed to do it.
I think this can be used CAS or UGOGO guideline. I think we've discussed that. And this is I think what you have addressed to a certain extent. So are there any predictors of developing Graves in those harboring thyroid stimulating antibodies? I think we've discussed this answer as well, but yeah.
I think Amrita, you can take this. We have a score, Predigo scores.
Predigo score we have only in those patients of Graves' disease, where we can see the cash and TBII and levels duration of hyperthyroidism, either more than 1 month, 1 to 4 months, or more than 4 months, and smoking history. So with a total score of 15, and it has a better negative predictive value. Those patients will not go to have a ophthalmopathy than a positive predictive value.
Hashimotoxicosis is the initial thyrotoxic phase due to destruction of follicles and release of preformed hormones. I think possibly this is the comment. This doesn't seem to be a question here to me.
Question, right?
Right, Vijay Bahadur. Okay, I think that's it then. So over to you, Dr. Arun, for the answers, please.
Yeah, ma'am. Thank you.
Slowly, you need to explain go through the question and explain why the answer is what is the right one. Okay?
Okay, ma'am. Okay.
Yeah.
So I'll share my journey also. This was a case which I saw 1 year or 2 years post DM. And normally what we read in the textbook is that Graves is a disease which will involve bilaterally symmetrical involvement of both the lobes of thyroid is there. But here what we saw was there was just a unilateral uptake, and there was so ultrasound done after this, because seeing this I thought this could be AFTN, but when the ultrasound was done it shows that there was no nodule. I asked the sonologist again, please cross check it again, because I was getting a scan with a unilateral uptake. Probably this would be an AFTN or something like that. But she categorically said that there was no nodule. And then after discussing with one of the professors of nuclear medicine from SGPGI, we could make the diagnosis of unilateral Graves' disease. And they say they see this case, asymmetrical Graves' disease very commonly, but unilateral uptake is rare. There are very few case reports in the literature. So this we published this paper in one of the journals. And which of the following should not be the management? So this is an important thing. Learning from this case is never go for hemithyroidectomy for these patients, because one of the patient, at least two patients in the literature, they went for hemithyroidectomy, and one of them they were suspecting carcinoma, so he went into they took this hemithyroidectomy, and one they went for the management of Graves' disease. And what happened is after a few months, they again developed the symptoms of Graves' disease. So it should be a treatment which should direct both the lobe. So a radioactive iodine medical therapy or lithium, if suppose the medical therapy is contraindicated. Hemithyroidectomy is not indicated as a treatment of unilateral Graves' disease. So, there are at least two cases in the literature wherein they underwent hemithyroidectomy and there was repeat involvement of the other lobe. So this question is fairly self-explanatory. The limbs involvement is more in. Yes, sir.
Can I interrupt you slightly?
Yes, sir.
What is the explanation of this unilateral Graves' disease?
So
or what is the natural? If given sufficient, do they become diffuse Graves' disease?
So the mechanisms is not well known. They have proposed few theories for that. One of the theories is that congenitally right lobe of thyroid is developed first than the left, and usually the right lobe is a bit larger than left lobe. So if we see this, most of the time the unilateral Graves' disease is for the right side. So this is the reason why they say that this is probably is something to do with the congenital development of the thyroid gland. Then second, they say that there are some other case reports of involvement of, say, one particular disease in one lobe and other particular lobe having other disease. And so the mechanism, they say, is probably differential infection of the lobe of the thyroid by some virus which led to predisposition to the disease, and the other lobe was uninfected. So these are the few mechanisms or theories they have proposed, but there is nothing there which can say with authority that this is the mechanism why it happens.
But in that case, radioactive iodine should not be a choice, isn't it?
So it has worked in many of the. If we see this, I have in this review of the cases, in many of the cases, this radioiodine ablation, it worked.
But the other lobe will not take the radiation, isn't it?
Yeah, I agree, sir. This is an area which is very less things are known about this thing.
I agree, but theoretically, if you believe that this is a bilateral disease and therapy should be targeted to the both lobes,
yes, sir,
be on right side treatment. So giving radiation will be definitely only right side that uptake will take it. Left will be suppressed or not taking up. So the chance of developing disease again on the left side remains.
It may remain theoretical.
Just to add in that, because even when we talk about the unilateral Graves, one of the theories which has been postulated is there is a differential expression and function of the sodium iodide importer iodine uptake mechanism. So as you are telling, this could be a thing, because I don't think there is enough in literature to comment on that, but that is also one of the mechanisms which has been postulated.
Yeah,
So,
so this is probably differential infection by the virus of
Yes.
that receptor.
Medical line of
Like,
treatment.
that is one, and the differential expression and function of the iodine uptake mechanism also happens over the sodium iodide importer. That is also one of the mechanisms, and also the response to the TSH receptor stimulation could also be one of the differential response to the TSH receptor stimulation happens. So as you're telling, this could be one of the things, but not much data is there, because if you see, only few cases of unilateral Graves has been reported, and
Yeah,
like Dr.
around
Arun pointed
10.
out. Yeah,
Yes, sir.
like there was one more case series where they have reported some more. So like it's not too much. It's like a small number. That's the thing.
Yes.
But that medical line of treatment should be the drug of choice in these patients.
With this patient now, it has been almost like 7-8 years. Ultimately, we had to give radioiodine, and she was having just unilateral uptake, and she has responded very well to radioiodine ablation. This is now almost like 6-7 years post radioablation. She's hypothyroid now.
She became hypothyroid?
Yes, sir.
So other side would also have taken up, but there may be a lesser uptake. So that's why probably the one which was over functioning might have totally become non-functional. The other side would also have, but maybe the differential uptake might have happened. That is what we can say, because that's also one of the mechanisms which people say is
That
there.
was good. Heart stimulating.
Yes, sir. Yes, sir. With this, I was struck with this case for at least months. Then I had to discuss with a lot of people, and finally we could reach to the diagnosis. And so the trunk involved, if we see in hypothyroidism, the limb involvement is more as compared to trunk. And this is again the differential diagnosis of increased TSH, normal T4 and normal T3 is macro TSH. TBG deficiency will have low normal TSH, low T4 and low T3, while TBG excess will have normal TSH, increased T4 and increased T3. Thyroid hormone resistance, not all, there are some types which can have this similar presentation, but not all types will have this thing. So again, this is if we see, this patient had a slightly raised TSH, T4 and T4 was normal. There was dyslipidemia, hypoalbuminemia, and urine protein 2 grams. So all was pointing toward nephritic syndrome. And so this patient was actually having nephrotic syndrome. Free T4 or the thyroid is a very small molecule. It is also excreted in the urine along with the proteins. When individuals have proteinuria, that's the reason why they might have increased requirement of levothyroxine when they have nephrotic syndrome. So now this was we were discussing about periodic paralysis. It can be associated with Graves' disease, thyroiditis, and toxic MNG. So the answer is all of the above. We have presented a case series in IgM, and what we saw, most common cause being Graves' disease, but it has been seen with toxic MNG, also with primary hypothyroidism and painless thyroiditis. So fairly almost all of the spectrum of the thyroid disease, they can present with periodic paralysis. So this was a series we published in IgM. Then a patient of lung carcinoma on leronlimab. So this is an important thing which probably will see more cases as newer drugs for oncology. This particular class of drug, checkpoint inhibitors, they are being used more now. So one of the oncologists at an institute in RML Institute, he was treating a patient with leronlimab for lung carcinoma, and the thyroid function was abnormal. He sent that patient, and so this patient was having immunotherapy-induced thyroiditis. So usually sick euthyroid can be also differential, but the suppressed TSH and raised T4 and T3 was against this thing. Also, Graves' disease, it is not that common with, it is almost like not reported. I'm not aware whether it is reported with nivolumab, and it would have always increased uptake in the scan. So this is an interesting thing. So like we were discussing in the first or second question, unilateral Graves' disease, it occurs most commonly on the right side, not on the left side. In fact, I was surprised to see that this was a paper published in Thyroid Journal, which has very good impact factor. First reported case of unilateral Graves' disease in the left lobe of a bilobar thyroid gland. So with hemigenesis, there were few case reports definitely there wherein there was Graves' disease. But in the bilobar thyroid gland left lobe normal, this was published in Thyroid Journal. So again, for thyroxine replacement supplementation, bone density, cortical bones is more affected as compared to trabecular bones. So this was the answer for this case. Trabecular bones are not that much affected as compared to cortical bone. So now again, this was an interesting case which we came across in our practice. This was a 65-year-old female. She was having primary hypothyroidism. And I have just reused the history actually, but what was happened when she came with recurrent hypokalemia, she was having an adrenal nodule. For this, they asked me to come. At the time of stress, when she was having hypotension, her cortisol was less, 300. So we started her on steroid and also some management for hypokalemia. Fortunately, she improved. But every time she was having hypotension and we were giving her steroid, usually in the triple the dose which was required. So after 3-4 months after this, what we did a cyclical stimulated cortisol. Cortisol was normal. And then we stopped this hydrocortisone. Again, what happened within few weeks, she presented with hypokalemia. And then we worked up again. First time also when we worked up, the biochemistry was suggestive of Bartter syndrome. There was hypokalemia, there was kaliuresis, UTKG was increased more than 4. Then there was also chloride urea, and sorry for this, the patient was having also calciuria. So first time at the diagnosis, when the steroid was given, the hypokalemia improved. As soon as the steroid was stopped, the again hypokalemia worsened. So this all lead to us to a diagnosis of autoimmune Bartter syndrome. So there are very few case reports in literature. 4-5 case reports are there. This is the table of that case. And so this patient was having actually Bartter syndrome. We presented this paper in Rheumatology International, acquired Bartter autoimmune Bartter syndrome in a patient of primary hypothyroidism. So this was a case diagnosed at our hospital with the help of nephrologists and rheumatologists. They were there for my sake. That's all from my side. Now over to the Patwardhan sir.
Oh yes, thank you very much, Pandey.
Yes, sir.
You've done a good job of enlightening us about many interesting cases. Anybody having comments, madam?
Yeah, I think because he has put in his personal experience and he's used his own publications.
Yes,
but
yes,
I hope was there a publication from TRP as well? I mean, one question from TRP.
Ma'am, it was there, but you asked me to remove that.
Oh, I didn't. Pramila will not forgive me now.
Actually, ma'am, the condition was that question should be such that it should not be there before.
Absolutely. So we want to avoid duplicity because it's all on the website. It's all on the website. So this is absolutely novel. I really enjoyed that quiz. I'm sure everybody did here as well. So I think we've actually overshot way beyond what we should have. So
one thing I want to add, so the macro TSH assay, so this was not available before. So Metropolis has been kind enough that I along with one of the doctors there, Dr. Neeraj Sanghvi, we developed this assay first time in India, macro TSH assay. Unfortunately, we have not published that paper, but the Metropolis has been very supportive that we have developed this assay in India. And if suppose somebody suspects macro TSH, then Metropolis does that in India.
So our journal is waiting with open arms, open access, everything. Kyun, Pramil?
Yes, ma'am.
They are welcoming.
Articles are welcome and all case reports are welcome to Thyroid Research and Practice. This is a journal of Indian Thyroid Society.
Yeah, because thanks to you, then we will be in PubMed and then we will have definitely, it makes that impact factor when it comes in, then it improves your readership, your publications, and I think everybody's familiar with that. So I think Pramila, any words before we close?
I think, ma'am, something is left. Ganvi.
Ma'am,
Yeah,
we have like announced the quiz winners yet.
Announce that, ma'am, the winners.
Yes.
Dr. Arun has to announce.
Arun, it's your privilege.
So the winner of the quiz is Dr. Anima Sharma first, then Dr. Lakshmi S second, and Dr. Anis Joseph, he is third.
Does anybody know where they are from? I think maybe Pramila students are the ones who are always ready to answer.
Today they are not there. I have to check if they are joined.
Anyway.
They were supposed to. They would have joined. They told they have joined, but maybe this time they didn't win.
Congratulations to all three of them.
Yeah, congratulations.
So Dr. Patwardhan, any last words, any take-home message, Pramila?
I think, ma'am, just please, if you have any articles or any case reports, we have the journal Thyroid Research and Practice. The website is active. You can submit there. After peer review, we'll decide for it. So please submit your articles, because we need articles for our journal, and it's a journal of the Indian Thyroid Society. So please submit.
Sure, ma'am.
Yeah,
So I'm happy to announce that we are back. So Indian Thyroid Clinics is back again, because we had we temporarily suspended it because a whole long month of thyroid awareness. We were doing a daily public awareness program with 3 moderators, beg your pardon, 3 experts, 1 moderator. So we kept it on hold till then. Now we'll be continuing the awareness once a month, first of every month. So 1st March, April, May, June, etc. But like Ganvi said, these will be most probably the 2nd. I think, Ganvi, we will focus on the 2nd of every month, because I looked into the dates and it wasn't working out very well with the 3rd. And it was clashing with a lot of other commitments. So we will continue. So you want to, okay, she wants to tell us something before I move on about the next,
Yes.
the 15th of March. Yeah.
So the next session will be on 15th of March, the details of which are displayed. So the chairperson for the next session will be Dr. Vikrant Gatnati, sir, who's the professor and head Department of Endocrinology, JNMC, Belgaum. There'll be a panel discussion by Dr. Ritesh Agarwal, Dr. Amaya Joshi, and Dr. Gaurav Malhotra on differentiated thyroid cancer, a team approach. Following that, there will be quiz by Dr. Srinath Shetty, sir, and followed by a monologue by Dr. MJ Paul, sir, on medullary carcinoma of the thyroid. To conclude, I would like to thank Dr. Ipshita, Dr. Patwardhan, sir, Dr. Arun Kumar, sir, Dr. Sweekruti, and Dr. Amrita. And I also thank all our esteemed conveners, and I thank the IT team. Though there were technical glitches, I think we concluded it successfully. Yes.
Yeah.
Yeah.
Thank you. Thank you, Ganvi.
Thank you.
It was a very good session. Thank you,
Thank
everyone. Dr. Patwardhan, Ipshita, your residents, Arun. Wonderful quiz. Thank you. Thank you, Ganvi, Pramila, Minnie.
Thank you.
I think Arun was not able to join us today. Sweekritu and Amrita as well. And of course, congratulations to the winners of the quiz. So join us on 15 March again, please.
Sure,
Same
ma'am.
time. Thank you. Thank you very much.
Thank you so much. Thank you so much, ma'am. Thank you.
Thank you. Thank you. Bye-bye. Good night. Good night, everyone.
Good night. Good night.